Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project. Thank you all for joining us today and our friends at Generations Family Health Center for hosting Erectile Dysfunction, Evaluation and Treatment More Than Just a Pill with Dr. Kenneth Snow. Dr. Snow is Chief Scientific Officer for Sequel MedTech, a maker of an automated insulin delivery device. Prior to that, he served as Medical Director at Insulin Corporation, as Medical Director for Clinical Strategy and in the Medical Affairs Division of CVS Health. Previously, Dr. Snow was on the staff of the Joslin Diabetes Center in Boston for 19 years, including 5 years as Chief of the Adult Diabetes Section. Additionally, he was Assistant Professor of Clinical Medicine at Harvard Medical School. And Dr. Snow, we're just very thankful to have you here and as a MAVEN Project volunteer. So when you're ready,
Kristen, thank you. And good morning, everyone. Thank you for taking time out of your busy day to learn a little bit more about erectile dysfunction and evaluation and treatment. And so with that, we'll jump right in. Other than what you heard already, I have no other disclosures to report. And the goals for today, the objectives, first off is how to evaluate a patient with erectile dysfunction, to review available options for therapy for erectile dysfunction, and also to assess the adequacy of treatment and potential side effects for patients who opt for treatment. So, why should we be concerned? I mean, why is this really a health issue that we really need to take note of? Well, first of all, it does affect quality of life for our patients. It certainly influences the general health perception of men. It is clearly an unmet medical need. It may reveal other common disorders that primary care clinicians routinely treat: hypertension, dyslipidemia, diabetes, major depression. So this may be the way that those disorders either become recognized, or what drives the patient to the physician to allow them to then have the opportunity to assess the patient. So how do you start this conversation? That's often one of the greatest problems. Is just like, how do we break the ice on this? And one simple screening question for ED: many men with your medical condition experience sexual problems. Has this happened to you? So that just as review of if they have hypertension or hyperlipidemia or diabetes, or whatever medical condition, this is a very easy way to break the ice and gives that patient permission, basically, to bring up the subject. So as we think about male sexual dysfunction, there's a number of ways that it can be subdivided and thought about. And so I break it down here in 4 different ways. It's a very common way, this is from Ullman, to think about this. There are disorders of libido, so essentially desire, diminished or excessive. Disorders of erection, of which erectile dysfunction is clearly one problem. Prolonged erections or erectile deformities are others. A third is disorders of ejaculation, so either premature or delayed, or lack of ejaculation, or retrograde ejaculation, anorgasmia. And then there's pain disorders, so either Peyronie's disease or just chronic pelvic pain syndrome. And so for today, we really are focusing on disorders of erection, and particularly in that erectile dysfunction. So ED is associated with a number of risk factors, age being one of the greatest. So men over the age of 70 have an increased risk of ED 6-fold. Diabetes is also a significant risk. As you can see, age under 70, but folks in their 60s, it's 3 times as great. Hypertension, depression, and a couple that often go unnoticed. It's not exactly clear why, but lower educational attainment level. This may be due to other unhealthy health practices that are seen. So less than 5 years of education, unemployment, certainly related with stress, and lower urinary tract symptoms, so non-specific symptoms does also increase the likelihood that someone will also report ED. Here's data from the Massachusetts Male Aging Study, which looked at the prevalence in the population of men. Okay, so this is the prevalence of population of men in Massachusetts. And since I am coming to you from Massachusetts, this could have included me. But the rate that we see, clearly age associated with it, with increasing age from 40 up through 70, you see that there's greater degree of erectile dysfunction, but also note that it depends on severity. So we see whether there's complete erectile dysfunction, a moderate dysfunction, or minimal dysfunction. And even for men in their 40s, you do see that a significant percentage of the population of men in their 40s will note at least minimal erectile dysfunction. So as we talk about other disease states, diabetes, dyslipidemia, hypertension, why are these associated? How does this all come about? And we know that all of these conditions, along with smoking, leads to oxidative stress and endothelial cell injury. And usually you'll see this slide or a slide similar to it regarding peripheral vascular disease or cardiovascular disease because of the endothelial cell injury, but often left off that slide. But here on the lower left-hand corner is erectile dysfunction, because again, it services it arises from the same common pathway, and so the same set of injury leads to ED as it does to cardiovascular disease, and so the same risk factors for cardiovascular disease are risk factors for ED. So what's involved in diagnosing ED? And sometimes it seems like kind of a silly question, but there should be a basic evaluation of sexual dysfunction, so sexual, medical, psychosocial history, a very focused physical exam necessary. So clearly, general exam, testicular exam, vascular exam. Recommended testing, usually nothing particularly unusual or that's probably not already been acquired for other routine reasons. Glucose level, lipid level, serum chemistries, particularly looking regarding renal disease or liver disease, CBC, testosterone. That's usually all that's required, unless there's something directs you towards a specific entity. The one thing we'll point out that empiric trials of therapy, so just giving somebody a pill, let's say, are discouraged without this basic evaluation. Obviously, if there's a significant cause behind the ED and the ED is a symptom of, let's say, diabetes that's been undiagnosed, there'd be a horrible opportunity to have missed the chance to be able to diagnose these folks. So that's certainly one reason. And the other is that clearly there can be other significant medical conditions going on that will be picked up either by history or physical exam. Now, in thinking about therapy, regardless of the type, there's always the question of, but what about cardiovascular disease? And I just mentioned about how these share a common pathway. And so clearly this is a population that is more likely to have cardiovascular disease. And sexual activity is a form of exercise. And so is it safe to treat these folks? So a basic clinical cardiovascular evaluation goes a long way. If this is somebody with low risk, you can initiate or resume sexual activity and hence therapy for sexual dysfunction without concern. This would be the same as somebody who was not complaining of erectile dysfunction, but came in and just asked, hey, given my heart status, is this okay? If the answer is they're low risk and you'd feel quite comfortable recommending that They either participate in a new in sexual activity, or if they were starting a new form of exercise of any type, and you'd feel comfortable recommending that, then you should feel pretty comfortable recommending therapy. If in their high risk, they're telling you they have angina. You know they have angina. It's not adequately treated. Obviously, these are folks that you would not recommend that they start a new form of exercise, and as such, you would not want to recommend treatment for their sexual dysfunction until their cardiovascular status has been evaluated and stable. They get on a good adequate medical regimen, or if they require a procedure of whatever type, until these are taken care of. It's the group in the middle, if it's kind of indeterminate, if they have a mid-range risk, these are the folks where you can consider doing a greater evaluation. Do they need to see a cardiologist, or do they simply need a stress test to be sure that that you feel comfortable recommending a new form of exercise for them, and likewise that it is safe for them to participate in. So getting a little bit more into the weeds here on the diagnosis of erectile dysfunction, what do we talk about in the history? Well, first off is what exactly is the problem? Because remember I mentioned about those 4 different categories of male sexual dysfunction. So if we're talking about ED, you really want to make sure that the complaint they're talking about is erectile dysfunction. Because if they're talking about anorgasmia or retrograde ejaculation, treating them for ED is not going to help. So what exactly is the problem? How long has it been going on? Is this a long duration problem, or is this new onset? And was the onset gradual or sudden? Physiologic reasons, usually pretty gradual, slowly over a long period of time. They've noticed it change. Whereas stress, psychological issues, usually much more sudden. Is it situational? What's going on in their social setting? What kind of stress are they at home or at work? I had a graduate student going through their PhD thesis. I can't think of too many more things more stressful than that. So, what's going on around them? What other medications are they on, both prescription and non-prescription? Because remember, many of these folks have sought out treatment on their own, on the web, health food stores, etc. At best, some of these can be neutral. At worst, some of them can actually exacerbate the problem. So what else are they taking? And then, of course, any other substances, particularly tobacco and alcohol, nutraceuticals that they'd be doing. So how do we assess the degree of the problem? So there's a couple of ways. There's a number of different surveys out. I mentioned 2 here. The International Index of Erectile Function, the IIEF, or the Global Assessment Question, referred to as a GAQ. Why use these? Well, they do complement to history and physical. It's real easy to facilitate an open communication. So if you ask somebody to fill out a survey, it then doesn't seem very strange to either you or them that you then want to talk about the results of the survey. Can be used to monitor therapy. So if you do opt for treatment for your patient, are they getting better? And it is how efficacy is measured for various therapies. So let's talk about these. So the IIEF, widely accepted tool, excellent properties concerning convergent, divergent, discriminatory validity, sensitivity, specificity, all those statistical things that you'd want out of a survey. It's statistically validated, more than 1,000 men with ED, 100 without ED. So this has been a validated survey, and it's been used in every major trial with all the oral treatments of ED. And it's simply 6 questions, and they're listed here regarding how often they're able to get erection. When you had erections, how often were they adequate for penetration? When you attempted sexual intercourse, how often were you able to enter your partner? During intercourse, how often were you able to maintain your erection after penetration? During intercourse, how difficult was it to maintain your erection? And how would you rate your confidence? And these are simply scored on a 1 to 5 basis. And so less than 10, severe disease, greater than or equal to 26, normal function. So you don't have to get perfect score. And then graded varying degrees of impairment in between. So it's pretty simple to do. And so you can see how this can certainly be used not only for diagnosis, but also to follow your patient who gets treated. Now, the GAQ is really simple because it's one question. Has the treatment you've been taking over the past 4 weeks improved your erection? So you say, wow, that's great. I just asked one question, and I'd probably be asking a question pretty similar to that anyhow. If I started somebody on treatment, they'd come back and I'd say, hey, did it help? And so because of that, it is the most widely used parameter to measure efficacy. It's clearly simple. It's easy to interpret. Did it help? Yes. Okay, great. And it provides responder rate information. What's the problem with it? The problem is if they came to you for help and you gave them a prescription and they then take it and you ask them, did it help? You may very well get the answer that says, yeah, kind of, a little bit. And that's not very reassuring that you've really improved things. So there's limitations on the GAQ because it doesn't give you gradation, and there's an incredible bias on the part of the patient to say yes because, hey, you're trying to help them. So they want to say yes. So when thinking about type of therapy, one way to think, thinking about types of therapy, one way to think about this and to approach this is efficacy, side effects, how easy it is, how invasive it is, and both the patient and their partner acceptance. And so if you look at different therapies that are available based on those criteria, and you ask folks for their preference, you get a result that looks something like this, which is the clear winner are pills, followed a distant second, third, fourth, fifth with everything else. Now we'll talk about everything else as well, but clearly pills are the winner because they are patient preference. And in terms of all the various criteria of efficacy, safety, side effects, etc., they're a good option. So let's talk about them. So these are PDE5 inhibitors, medications that are available. So what does PDE5 actually do? What is it? And hence, why do you want to inhibit it? Well, it's down in the lower right-hand corner there. If you can see the little green oval of PDE5. And what PDE5 does is it metabolizes cyclic GMP. So during normal erections, what happens is the stimulation, nitric oxide is released. This stimulates guanyl cyclase, which converts GTP to cyclic GMP. And this causes smooth muscle relaxation and an erection. So that's a fairly complicated process. PDE5 gets rid of the cyclic GMP. No more cyclic GMP, no more smooth muscle relaxation, no more erection. If you inhibit PDE5, you increase the amount of cyclic GMP, so you get more smooth muscle relaxation. So that's why you want to inhibit PDE5. Note, if there's no nitric oxide, there's no guanyl cyclase, there's no purpose to inhibiting PDE5 because there's no cyclic GMP. So where does the nitric oxide come from? Well, it's released by endothelial cells, but more important, it's released because of sexual stimulation. So this is a very long way of saying no sexual stimulation, no nitric oxides. inhibiting PDE5 is worthless. So keep that in mind when recommending these therapies, that if the person takes one of these pills and goes out and cuts the grass, they're going to have a very nice lawn, but they're not going to spontaneously, most likely, get an erection. They need sexual stimulation. So the only way they can tell whether the pill helps is through sexual activity. The three pills that are available, the three compounds that are available: Viagra, Cialis, Levitra, sildenafil, tadalafil, vardenafil, and the product names. Most important differentiators between these is sort of the rapid acting, shorter acting drugs, Viagra, Levitra, slower acting, longer acting drugs, Cialis. So this is just how long does it take to reach half max or to reach max concentration, and how long does it take to be metabolized. Note that all of them metabolized by CYP3A4. And so that's something to keep in mind regarding any other drug that goes through that pathway. But in thinking about what to prescribe, one of the major things is what's going to fit into the patient's lifestyle. If they want something more on demand, then Viagra, Levitra, having an onset of action faster, reaching a peak drug concentration faster, is probably going to be more successful than Cialis, which is going to have a longer duration of action. On the other hand, sorry about that. On the other hand, if this is somebody who is going to come home, they're in a stable relationship, knows they're going to be sexually active that night, they take the pill, wait a couple of hours, well, then they're going to have a longer duration of action of the drug, and this may fit in better. It's also very important that the patient understand these differences, because you do not want somebody taking tadalafil, so Cialis, taking a couple of hours before it's going to reach its maximum effect, and taking this 10 minutes before sexual activity, because they are much more likely to then fail, not because the drug didn't help them, but because the timing wasn't right. So a few things about pharmacodynamic interactions here. So PDE5 inhibitors, nitrates, and alpha blockers all cause vasodilation. So remember what I was talking about of how sexual stimulation leads to vasodilation and endothelial cell reaction. That's through nitrates and nitric oxide. Well, so if somebody's on a nitrate, that's going to contribute nitric oxide as well. And these all go through the same pathway causing vasodilation. And so the combination can have significant adverse events. So the PDE5 inhibitors reduce the breakdown of cyclic GMP. Systemic vasodilatory properties can result in transient decreases in blood pressure. And this has been shown in healthy volunteers. Take young men in their 20s, no erectile dysfunction, no vascular problems, and give them a combination of a nitrate and a PDE5 inhibitor, and they can drop their blood pressure significantly. So then fast forward to somebody in their 50s or 60s, and maybe a little cardiac disease, granted it's stables, and put the two together, and this can be catastrophic. Alpha blockers also inhibit the pressure effects of epinephrine, so it leads to a fall in peripheral vascular resistance, and so it's associated with the first dose postural hypotension and syncope. So on an alpha blocker, and certainly if they're on a nitrate, but if they're on an alpha blocker and a PDE5, if they stand up quickly getting out of bed, they can get lightheaded and fall down. So again, something patients should be aware of getting up out of bed, particularly the first couple of times they've used the drug. They want to see if they get a little postural hypertension, dangle the legs on the end of the bed for a few seconds before getting up. And certainly the additive effects of combining these classes of agents can be significant. So make sure patients are aware if this is a potential combination therapy that they would wind up on, that they're getting they're getting a PDE5 inhibitor and they're on either a nitrate or an alpha blocker. So let's move on to other therapies. So I'd consider that there's 5 classes. There's intracavernosal injection therapy. There's a urethral suppository, medicated urethral suppository for erections. There's a vacuum assistant device or constriction devices. There are implants and no therapy. And I include that because that can be an active decision and probably should be an active decision. So but in shared decision making between the provider and the patient, that they decide not to go with therapy, either because of medical risk that it's unwise, or because the patient is choosing not to, that is certainly, their right and a wise decision if they're actively making it. But they should be making that decision as opposed to therapy never got offered to them. So let's talk about injections. Now, the one thing to keep in mind is that there are relatively few, and I stress few, pain sensors on the lateral side for the penis. That is dramatically different from the tip. What that means in reality is this is relatively painless. Actually, it's quite painless. You just need to convince your patient of this. This is truly selling used cars, because no one's ever going to believe you until they do this. But it is relatively painless. What's available for injection? Well, there's alprostadil. It's a synthetic prostaglandin. It's rapidly metabolized. It's very useful in treatment and diagnostic testing. Just yesterday, as I was driving, I heard one of the commercials on the radio where come into the office and we'll give you a test dose, and if it doesn't work, well, then the visit is free, because you can do a test dose and see if they respond. Most men are going to respond. Talk about this in a second. There's dosing concentration, which I won't get into details of for this lecture. Efficacy, it will initiate an erection across all etiologies, regardless of problem, 60 to 70% of the time. And it is superior to papaverine or papaverine-phentolamine combination, which, by the way, are not approved for this use, but commonly used by urologists, particularly in the past. And so the therapy has a high efficacy rate. The problems, mostly local. There is the prolonged erection priapism, pretty rare, but definitely measurable. Can be some fibrosis. Different studies have a very wide-ranging range of the frequency that this occurs. And there can be painful sensations. About 10% of men will note some pain. Of course, that means 90% will note none, but 10% will note some. Either in the injection or just in the injection or in the erection itself. So just the tissue expanding can provide a little bit of pain, particularly if they haven't had erections in a long time. The alternative is what's referred to as trimix, which is a combination of the alprostadil along with papaverine and phentolamine. It's an unapproved therapy. It is widely used in the United States. It's been used for many, many years. Urologists have been using this and who do ED therapy, and they feel comfortable with it. It is the most potent intracavernosal injection therapy for ED. It is superior to alprostadil alone, and the response is as high as 90%. I suspect the radio commercial I heard, that's what that urologist was using. because that's why you could guarantee that if the injection didn't work, the visit was free because it knows that this has a greater than 90% efficacy rate. The adverse effects, well, you have an increased incidence of priapism and penile fibrosis compared to alprostadil alone. And there's not good studies of exactly what the rates are, but they are higher than alprostadil alone. Not surprising. And again, note this is not approved by the FDA, but you should be well aware of it. Not so much that I suspect, this audience today are going to be doing this. But because your patient, if you refer them to urology and they or to a physician who specializes in ED therapy and uses this therapy, you should be aware of what they're getting. The alprostadil also comes as a medical suppository that's inserted into the in through the urethra and then absorbed that way. Major side effect is penile pain. It can cause some dizziness or hypotension, mostly a vasovagal event. But the mechanism of action, it's alprostadil, so it's a prostaglandin and causes vasodilation. Vacuum constriction devices, they're externally applied. Some are have a mechanical pump, others will have an electrical pump. Regardless of what powers the vacuum, the cylinder is placed over the penis. It creates a closed chamber because the cylinder itself is closed, all except for the obvious end that goes against the body, and that is wedged up against the body, creating a seal. So you have a closed chamber, it results in a vacuum, it draws venous blood into the corpus cavernosa, and then there's a constrictive ring that slides off the end of the vacuum device and onto the base of the penis to maintain the suctioned blood in the penis, and so it maintains the erection. Efficacy of this is it uniformly produces an erection. And studies usually reports patient satisfaction around 50%. The advantages, there's an on-demand use. So there's no waiting, there's no timing, there's no injections. It's just on demand. There's no systemic side effects. And the cost, other than the one-time upfront cost, which often is covered by insurance, there's no ongoing cost of use. So there's no drug, there's no ongoing cost. The disadvantage, the number one disadvantage is the extraordinarily obvious thing. It's cumbersome. So it needs to be acceptable for both the patient and their partner. Just as a side, the partner is usually more accepting than the patient. It's not an absolute statement, but it's usually true. Part of that may be that their partner is also concerned about the patient's health, their partner's health, and so they feel very comfortable that there's no drugs involved here, so there's no side effects. So that's can be an advantage for the partner, but it is cumbersome, and there's no way around that. And it's an unnatural erection. And what I mean by that is that this is a venous blood, and so a couple of things that the user or their partner may notice is that the penis is a little more blue than usual, and that it can be a little colder, about a half a degree to 1 degree colder. Not enough that this is of any significance, but it may be noticed. Side effects, you can get petechiae, ecchymosis, particularly with the manual pumps, if somebody gets a little bit too aggressive. There can be penile pain, particularly, boy, that's a lot of peace. Penile pain, particularly if the person has not had an erection for a long time and that tissue is stretching out. One of the ways around that is to recommend that they don't try to achieve as full of an erection as possible the first couple of times they use it. The constriction ring can cause an ejaculatory blockage, which result in retrograde ejaculation. That is not of any significant health problem. Could be a concern to a patient if they're not aware that it could happen. So they just should be educated on that. It obviously is an issue if they're trying to conceive or if they're trying to have their partner conceive. There can be a little bit of numbness. And there's also the effect of penile hinging. And what's meant by that is distal to the constriction ring, there's an erection, but in the part of the penis proximal to the ring, where it connects to the body, it's still flaccid, which means that the penis can bend. So they have to be a little careful regarding sort of geometry. Next therapy is penile prostheses. So these come in two forms. They're implanted surgically inside the corpus cavernosa, and they mechanically produce penile rigidity. There's the malleable ones, the semi-rigid rods, which manipulate the penis into a erect position, soft enough so that they can bend. Person will have this, under their clothes, etc., when they go about their day. But they're rigid enough for sexual penetration. And then there's the inflatable ones, which have an enclosed cylinder connected to a pump or reservoir system that works. You can think of it as an inflation bulb, kind of like a blood pressure cuff, except it's not a bulb sitting exterior to the body. The bulb is placed in the scrotum, and so the person inflates the cylinders by squeezing on the bulb that's within their scrotum, so it's all internal, and that causes the erection, and then they can release it through a release valve that allows the system to deflate. They are highly effective, regardless of the cause. Success rates around 90%. The advantage, they're curative, spontaneity. The disadvantages are they are an unnatural erection. They do require surgery. There is a potential for complications. They're fairly low rates of complications, particularly with the semi-rigid ones, which are obviously much simpler. There can be mechanical failure of the inflatable rods. Either kind, there can be infection or erosion through the skin. As I say, these are very rare, but they do occur. This is irreversible therapy. You destroy the natural corpus cavernosa tissue doing the surgery. And then, of course, cost. The surgeries are not inexpensive. These are tens of thousands of dollars, and so it really does require insurance coverage for somebody to be able to take advantage of it. So in summary, ED is common. Screening for ED can be part of routine evaluation of men's health. PDE5 inhibitors are the most common form of therapies used. Other options do exist if the PDE5 inhibitors fail. And even if, as a provider, you are not going to be prescribing those, it is useful to know that they exist, to be able to refer your patient for them, and to understand what therapy they're getting when they come back to you. And with that, I say thank you and happy to open up for any kind of questions that you may have.
All right, thanks, Dr. Snow. I'm going to move there. Okay, so we don't have the sun in our face. If you have any questions, please put them into the chat, the Q&A box, or use the raised hand feature. We will start with this first one. Are there any recommendations regarding a max number of pills that should be taken per day, week, month?
Yeah, so you don't want to overlap drugs. So depending on which drug, so if you're taking a short-acting agent, which is going to have a half-life of somewhere on the order of, 4 or 5 hours. You can certainly do one a day. For Cialis, you're not going to be wanting to do more than 2 to 3 a week. Now, keep in mind that's usually that's way beyond what usually coverage from an insurance will cover, or what most folks are going to be willing to pay or desire. So it's usually not limiting, but much more frequent than that. You may get a little bit, particularly with the Cialis, or if you're let's say with the shorter acting drugs, more than one per day, you're going to be getting some overlapping effects. So you'll be getting some higher levels of PDE5, and the risk of that is a greater risk of side effect.
Great. If someone is on an alpha blocker like Flomax for BPH and there is a risk of postural hypotension, as you said, should we pick a shorter acting medication like Viagra to start? And at what dose should we start?
That's a very common and wise way to start. So, that I think 25 is kind of non-therapeutic for ED. So, start at 50 and just make sure that they're aware of the postural hypotension effect, so that they don't get up out of bed quickly. So sit up, dangle the legs. If you're feeling a little bit dizzy, lie back down. That is the good thing about the fact that they're in bed, or assuming they're in bed. And see if they have the effect. If the 50 works for them, then there's no reason to increase. If the 50 is either unsuccessful or only moderately effective, and they're not having significant problems from postural hypertension, then you can feel more comfortable about going up to 100, and again warn them again about the potential. So it's a good way for for folks using alpha blockers to get on therapy, and rather than give them the 100 straight off.
Great. For a male who is around 40 with ED, what is considered a normal testosterone level?
Oh, yeah. So, you get this testosterone from, report from the lab, and we'll say, oh, 3 to 900. And it's like, really? Because they take a whole group of, normal ranges come from a whole group of, normal, whatever that is, folks. They don't have disease related to the thing you're measuring. And, if you get a spectrum across, and you get this range of, get rid of this, of 3 to 900. Yeah. Men that age, usually testosterones are north of 450. But this leads to which leads to the very interesting question of what happens if I have a 40-year-old and their testosterone level is 350 or 380, which is going to be which is technically within the normal range, and technically does not meet the require for low testosterone by any of the major societies. Do you give them testosterone therapy? And this is highly debated. You can find folks who will say, absolutely, this is a problem. You can find other folks who will say, no, 300 is adequate. So even if it's low for them, it's adequate. There's no good final decision on it. My own personal view, a trial, there's no harm to a short-term trial. This will be, giving, that person some testosterone, rechecking their level, seeing if it goes up, above, let's say 450 or so, and seeing if they get any kind of significant improvement. And I think the most important cautions on this is, one, remember why you're doing this. It's somehow it seems to get lost sometimes. They get on testosterone and then they just stay on testosterone. If they're having ED and they have a testosterone level of, let's say, 350, and you choose to treat them and you bring the testosterone level up and they're still having the ED, there's no reason to continue it. You've made the number prettier, but you haven't solved why they got started on it. So don't continue it, because it's not doing any good. The other risk of testosterone is abuse. And you hear all these stories of in the gym and folks using testosterone off-label and all of this, and there's the youth mills out there that will give testosterone to anything that walks. Um, but obviously, that's not the situation here, where it's a healthcare provider understanding that there's a problem in a gray area of medicine where it's not clear, doing a trial of therapy to see if this therapy helps their patient. If it does, fantastic. If it doesn't, then discontinue it. That's my view and my take on it.
Thanks. What is the treatment for medication-induced priapism?
Priapism. Oh, yeah. So an erection that won't go away, which, yeah, I mean, despite every comedian on late night television making a joke about it when I think Viagra first came out, um, it's extraordinarily painful. Um, this can leads to, untreated leads to tissue necrosis, et cetera. The treatment is usually flushing the penis with fluid. So this is an emergency room visit and visit from the urologist. So that is the therapy. There's no good reversal for somebody truly experiencing priapism, the erection that, it's one thing if it's a little prolonged, an hour, but that's an erection that won't go away after 4 hours. This is not going to get better, and that tissue is at risk of inadequate blood flow because there is decreased blood flow in because of constriction. And so there is danger of tissue necrosis. So it's a medical emergency. And it's also, as an aside, one reason why a lot of non-urologists should be very hesitant to prescribing intracavernosal injection therapy, because it's not hard to do and it's not hard to learn. But you better have a good working relationship with a urologist, because if and when priapism occurs on a patient, they're the one who's going to be called in at 1 o'clock in the morning to take care of it. So you want to make sure that you have a good working. If they're prescribing, then it's their patient, and they prescribed a therapy that they knew had a particular risk, and they're skilled to take care of it. If it's your patient, you better have a good working relationship with them.
And just a quick follow-up, when is it recommended to go to the HR? Like how long?
4 hours. Now, that does not mean that somebody who calls in at 3 hours and 45 minutes, you tell them to wait 15 more minutes. I mean, kind of obvious, but I mean, this is, but it means if it's an hour, they're not at risk at that point. They can wait a little while, doesn't go down, because it's not going to be, if they do need surgical treatment, this is not going to be a pleasant experience for them. And certainly if they can avoid the emergency room. So you do have time at that point, but
Okay,
4 hours is the recommendation.
great. When checking testosterone, do you only check total? And what instructions do you give? For example, check at a certain time of day.
Yeah. So it's a great screening tool, the total, and will often answer the question for most men. And you want to check in the morning because there is a diurnal variation, so that testosterone levels are lower in the afternoon. It is, by the way, why many men, particularly as they get older, will notice that erections are better in the morning, because there is that diurnal variation. So testosterone levels are at their peak in the morning. If you check in the morning and the total is fine, they're fine. If it's either indeterminate, kind of on the border, or they have a reason why they could have a binding protein abnormality, or particularly if they're very obese, which increases binding protein, and so they can have normal free testosterone levels, but they can have if they may show up with a lower total. You can check a free testosterone, um, but usually a total is adequate, particularly a screening, and then only move on to a free if their total is kind of indeterminate. If it's really low, you have your answer. The free is a little less in many labs, it's a little less accurate, and it's usually much more expensive.
Great. Do you check LH and FSH if testosterone is low? Is there a role to check SHBG?
So SHBG, sex hormone binding globulin, there is in those indeterminate ones, as we were just talking about, the LH-FSH. Yeah, absolutely, if you're getting a low testosterone, because then the question is why? Now, most of this is going to be you're going to wind up with a whole bunch of normal LH-FSHs, which is that their testes, are just not adequately responding to what is considered a normal level of FSH. In reality, what it is they're not getting an adequate increase in their FSH to make up for the low testosterone level, so they're having an inadequate response. And so you'll see these normal FSH levels with a low testosterone. That's the usual result. But ones where you get a low FSH, then you have much more suspicion that it is central. And the most likely thing is going to be either prolactin elevation, particularly prolactinomas. They tend to be benign tumors, but they produce prolactin, or other pituitary tumors, which also tend to be benign, but they interrupt the flow of dopamine, and hence prolactin goes up. So you'll get an elevated prolactin. Some folks will argue that, hey, well, I'm sticking the guy because I've already drawn blood out of him once, and now I have a low testosterone, and I'm checking in LH-FSH, so now I'm drawing blood twice. Maybe I should just draw a prolactin at the same time. That's reasonable to do. It's not a particularly expensive lab test. Alternatively, some labs will have an automated response where if the FSH LH come back low, then it will automatically trigger the prolactin, however your lab is set up to do. Those are the things you'd want to look for. Look for the LH-FSH, see if it's low. If it is, check a prolactin. If they're sky high, if they're elevated, then you know it's primary testicular failure. And then there's question of whether there's a reason for that. Has there been injury? Is there a vascular issue? Usually those are picked up on by history and physical exam. The testes is small. Some reason that would direct you to primary testicular problem.
All right. Does use of Cialis at doses for BPH also help erectile dysfunction?
It can. I mean, there are reports. So there is some literature on this, but these, they tend to be lower doses, and particularly if it's more steady. So part of it depends on how severe the problem is, and as such, how likely they are to respond. Because remember, this is inhibiting an enzyme which is going to increase the amount of cyclic GMP. So if they have some not adequate, they have some erectile dysfunction, you inhibit the enzyme a little bit, they get a little bit more, they can get a response. So they can. So there is evidence that it does help some, but it certainly isn't going to be therapeutic for somebody who has significant, or most likely it won't be therapeutic for somebody with significant disease.
Okay, for patients who are on isosorbite nitrate
Mononitrate, yeah.
and they take PDE5 inhibitors, stable CAD.
Yeah. Start 25 milligrams of Viagra, or 20 milligrams of Viagra, and see if and warn them of dropping blood pressure. Remember, that's the concern. And so if they lie down, put their feet up, they'll be okay. So you do want to warn them of this risk, and it is a reason in somebody like that you might want to consider a trial, because they have nitrates on board. But you can use it, but you do want to warn them of it.
Would there be any concern with minimally elevated LH with all other testing normal?
Um, the concern, I mean, the concern would be a primary testicular issue. Um, um, so there's a number of far less common reasons that this could occur. Syphilis is one of them. Tuberculosis is one of them. Usually, this is not subtle. This is the only way you're going to find those diseases. So, um, trauma or let's say a unilateral loss of the testes, which may have occurred in childhood and they grew up and they're perfectly fine and functioned with one functioning testicle, but now they're getting older and they're losing function from that one. And so now their level's low. So you see a low testosterone and elevated LH. Now, if you're just seeing the elevated LH and the testosterone level is fine, then they're compensating, and so no problem. There's nothing that you need to be concerned about of a slight elevation in the LH. If you're seeing a real big elevation in LH, then you do have to suspect a gonadotropin releasing pituitary hormone tumor. Very rare, but somebody's going to find one. So if you get that LH level of 200 in someone who otherwise isn't complaining of anything, you want to look at the pituitary.
Thanks. I don't see any more questions, but we'll pause for any last minute questions. Please get them in. And just a reminder with your CME survey, when it pops up, today is October 9th, and today's speaker is Dr. Kenneth Snow. Okay. I just had a patient in his 50s with a minimally elevated T level done for eval of ED. BHCG was found to be elevated, and we found a 2-centimeter mass in his testicle cancer. Just a plug for doing testing and an exam. Oh, it's a plug. We love a plug.
It's a plug, yeah. I was like, thank you. Thank you for the plug. Yeah. It
Yeah.
I mean, you never know. You never know what you're gonna find.
Yes, and that is true. All right.
It's good. It's still good to be a healthcare provider, that we actually examine patients and doctor them and and you find things.
All right. All right. Well, then I think we're done with questions. I see little comments going in the chat, so I get a little confused. But thank you all for joining us this morning. Dr. Snow, thank you for a fantastic presentation. Just a reminder, if you have questions after this, you can always reach out to Dr. Snow or any of our MAVEN Project volunteers on the community portal. We love consults. Have a great day, everyone.
Great. Thank you all. Take care. Okay. Kristen, always good to see you.